Bismillahirrahmanirrahim. Today I am going to cover a new topic which is muscles of thorax, nerves, vessels, intercostal spaces, and skin innervation of chest wall. These are the objectives. First, I will cover the muscles of the thorax, nerves, vessels, lymphatic drainage of the thorax, then what is the skin innervation of chest wall, then what is intercostal nerve block, then thoracostomy and thoracotomy. The later three, the intercostal nerve block, thoracostomy and thoracotomy, these are the clinical procedures. First of all, I will tell you what are intercostal spaces. Can you see in this diagram? This is one rib and this is the lower rib, and this is the space in between the two ribs. This is called as intercostal space. That is, the intercostal spaces are the gaps between two adjacent ribs. If we pass one needle for any procedure, maybe thoracotomy or the intercostal nerve block, if we pass needle, this needle will pass through entire depth of an intercostal space. It will pass through entire depth of the intercostal space, and it will penetrate these five structures from superficial to deep sequence. These are the structures. Number one will be skin. Can you see skin here? This is skin. Then there will be superficial fascia. You have to see the cursor. Okay, you have to see the cursor, or I will on the laser pointer. Okay, see here, this is skin. Okay, this is superficial fascia. Then there will be deep fascia here. Then there are many intercostal muscles. See here, if this is another muscle which is serratus anterior muscle, it will depend on the specific location on the thoracic wall. This serratus anterior muscle may cover the intercostal muscle layer. Okay, so maybe sometime the serratus anterior will be pierced by the needle, or sometime the serratus anterior will not be present. It will depend on the location of the thoracic chest wall at which the needle is pierced. Okay, so it can be pierced or it cannot be pierced. Then what will happen? First of all, skin, superficial fascia, then there will be a thin deep fascia, then this is serratus anterior muscle, then the intercostal muscles will be pierced. This is external intercostal muscle, then there will be internal intercostal muscle, then there will be third muscle which is innermost intercostal muscle. Then deep to the innermost intercostal muscle there will be endothoracic fascia. So this is endothoracic fascia. Then there will be extrapleural fatty layer will be there. Then there will be parietal pleura. So there are three layers here in this blue part. What are these three layers? Number one is endothoracic fascia. Then there is extrapleural fatty layer, and then there is parietal pleura. Parietal pleura. Then the pleural cavity will come, and this is visceral pleura. Then the outer part of the lung will come, or the lung outer surface will come. So this is the diagram which you have to learn by heart, that what are the structures which are pierced by a needle when we are piercing the needle or crossing the needle in the intercostal space. So what are the structures? Number one is skin, then superficial fascia, then deep fascia, then three intercostal muscles. What are the three intercostal muscles? Number one is external intercostal, number two is internal intercostal, number three is innermost intercostal muscle. Then three layers which are internal to the innermost intercostal muscle. What are these three layers? Number one is endothoracic fascia, number two is extrapleural fatty layer, and number three is parietal pleura. The three intercostal muscles all act as muscle of respiration. These three muscles, they will act as the muscles of respiration. Okay, I have already told you the muscles which are from superficial to deep. Number one is external intercostal, number two is internal intercostal, and number three is innermost intercostal muscles. Okay, the innermost intercostal muscle is lined internally by the highly variable extrapleural fatty layer, and then there will be parietal pleura. The intercostal nerves and vessels. Can you see here in this diagram, the intercostal nerves and vessels, they run between the intermediate layer and the deep layer of the intercostal muscles. This is the intermediate muscle, which is the internal external intercostal, and this is the deepest muscle, which is the innermost intercostal muscle. So the vessel and the nerve, what are the vessels and nerve? Number one is intercostal vein, then intercostal artery and intercostal nerve. These three structures, they lie in between these two layers of the muscle. Okay, you have to learn the mnemonic, which I have already told you in the previous lecture of osteology. This mnemonic is VAN, VAN. V for vein, that is in blue color, A for artery, that is in red color, and N is in, or nerve is in yellow color. So this is vein. First of all, vein is present, then artery is present, and then nerve is present, which is in between the two muscles, which is the intermediate muscle and the deep muscle of the intercostal muscles. See here, this is the chart which I have pasted from Snell's. Okay, these are the thorax muscles. Okay, what are the thorax muscle? Number one is external intercostal muscle. Can you see this muscle here? Internal intercostal muscle. This is the outer muscle. Number one, there are 11 external intercostal muscles. Okay, in every intercostal space. What is the origin? It will originate from the inferior border of the rib above. See here, inferior border of the rib, and it will go down. Okay, it will go down. Okay, downwards and forward. It is going downwards and forwards, and it will insert over the superior border of the rib below. This is external intercostal, originating from the rib above, the inferior border of the rib above, and it will go downwards and forwards, and it will insert over the superior border of the rib below. It is supplied by intercostal nerve. The nerve supply is intercostal nerve. It will stabilize the rib cage. Okay, it will stabilize the rib cage. Then the second muscle, which is internal intercostal muscle. Can you see here? It is deep to the external intercostal. It is internal intercostal muscle. Again, it will originate from the inferior border of the rib above, but it will go down and backward. Okay, downwards and backward, and it will insert over the superior border of the rib below. Again, it will be supplied by the intercostal nerve. Okay, it will also stabilize the rib cage. These muscles, they will help in respiration. They are respiratory muscles, and they will help in the respiration. Number three, internal innermost intercostal muscle. First was external, then internal, then this is innermost intercostal muscle. These innermost intercostal muscles, they are present in the adjacent rib. They will be originated from the rib, and it will again insert over the adjacent rib. They are also supplied by the intercostal nerves. They will assist the external intercostal and internal intercostal muscle in respiration. Then diaphragm, which you will cover in a separate lecture by Dr. Amna. Okay, but I will tell you that diaphragm, it is originated from xiphoid process, lower 6 costal cartilages, and first 3 lumbar vertebra. Okay, then it is inserted over the central tendon. It is supplied by phrenic nerve. This is very, very important. Phrenic nerve is supplying the diaphragm. Okay, now another muscles which are levator costarum muscle. Can you see here levator costarum muscle? There are 12 levator costarum muscles in our body. They are originated from the tip of the transverse processes. See here, they are originating from the tips of the transverse processes on each side. See here, from C7 till T11. C7, that is the 7th cervical vertebra. Okay, then C8, T1, T2, T3, T4, T5, 6, 7, 8, 9, 10 and 11. Okay, so they will originate from C7 till T11, and they are inserted over the rib below. See here, they are inserted over the rib below. Okay, they are supplied by posterior rami of thoracic spinal nerves. they will elevate the rib. Okay, they will elevate, when they will contract, they will elevate the ribs. Now another two muscles which are present here on the back, actually they are back muscles. Okay, so this is serratus posterior superior and this is serratus posterior inferior. Why they are called as serratus posterior? Because there is another muscle which is serratus anterior muscle. See here, this is serratus anterior muscle which is present anteriorly, and because it is present posteriorly, so it is called as serratus posterior muscle. And why they are superior and inferior? Because this one is present superiorly, so called as serratus posterior superior, and the another one is present inferiorly, so it is called as serratus posterior inferior muscle. So this number one, serratus posterior superior muscle is originated from the spines of the lower cervical and upper thoracic spine. Okay, or upper thoracic vertebra, that is spine of lower cervical and upper thoracic vertebra. They are inserted over the upper ribs. Okay, they are also supplied by intercostal nerves. This muscle, the serratus posterior superior muscle, it will elevate the rib or raise the rib, and they are called as inspiratory muscles because they will raise the rib during inspiration. Now the serratus posterior inferior muscle, it will again originate from the spine, but originate from the spine of upper lumbar and lower thoracic vertebra. They are inserted over the lower ribs. They are also supplied by the intercostal nerves. They will depress the ribs during expiration. Okay, they will depress the ribs during expiration. So this is an expiratory muscle. I hope you have remembered all these muscles of thorax. I will repeat again. Number one is external intercostal muscle. This is external intercostal muscle originating from the inferior border of the rib, coming downwards and forwards and inserting over the upper border of the rib below. Then this is internal intercostal muscle. It is originated from the lower border of the rib and coming backwards and downwards, and it is inserting over the upper border of the rib below. These both they are supplied by intercostal nerves. They will stabilize the rib cage. Then the innermost intercostal muscle. This is innermost intercostal muscle. You can see here the vein, artery and nerve. They are present in between the internal intercostal and innermost intercostal muscle. Okay, in the upper part of the intercostal space or in the lower part of the you can say rib, or this is called as subcostal groove, which is present on the inner side of the lower part of the rib, which I have explained already in the previous lecture. Then the fourth muscle, that is levator costarum muscle. Okay, this is originated from the tips of the transverse processes of C7 to T1, T2, T3 till T11, and it is inserted over the rib below. Okay, they are also supplied by the posterior rami of the thoracic spinal nerves. Okay, the intercostal nerves, they are the anterior rami of the thoracic spinal nerves. So levator costarum, they will be supplied by the posterior rami of the thoracic spinal nerve, so not by the intercostal nerve. They will elevate the ribs during respiration. Then two serratus posterior muscles, because they are present on the back. One is superior, one is inferior. Superior one is originated from the lower cervical and upper thoracic spines, the spinous process, which is a single process in the middle of the vertebra. Then the lower one, that is the serratus posterior inferior, it is originated from the lower thoracic and the upper lumbar spine. They are inserted over the ribs, which are, if this is the superior muscle, then it is inserted over the upper rib, and the inferior muscle is inserted over the lower rib. They are supplied by the intercostal nerves. The upper one, the superior one, is inspiratory muscle. It will elevate the rib during inspiration. The lower muscle, that is the inferior muscle, it is the expiratory muscle because it will depress the ribs during expiration. So, you have learned three muscles again: external intercostal, internal intercostal and innermost intercostal muscle. Now see here, this is the intercostal space where they are present. Now you have to see their location. Can you see this black colored muscle outside? Number one, this is external intercostal muscle. Then number 2, inner to it is internal intercostal muscle. Then number 3, this is innermost intercostal muscle. See here, we will go one by one. Number 1 is external intercostal muscle. It is the most superficial of the 3 muscle layers. Its fibers are directed downwards and forwards, and as I have shown you, downwards and forwards from the inferior border of the rib above to the superior border of the rib below. This muscle, it will extend forward. See here, it is extending forward to the costal cartilage, where it is replaced by an aponeurosis. See here, this muscle is finished here, and it will be completed by an aponeurosis or a membrane which is called as anterior intercostal membrane or external intercostal membrane. This is anterior or external intercostal membrane. Okay, number 2, the internal intercostal muscle, which is the second muscle. It is present in between the external and the innermost intercostal muscle. This muscle extends backwards from sternum. See here, this is sternum. It will be originated from the sternum, and it will go backward from the lateral part of the sternum in front to the angle of the rib. Here there will be angle of the rib. So it will reach to the angle of the rib where the muscle is replaced by a membrane or an aponeurosis, which is called as posterior intercostal membrane or internal intercostal membrane. You can see in the diagram where I am showing you with the laser pointer. See here, this is posterior intercostal membrane or internal intercostal membrane or aponeurosis. Now we will go to the third muscle. Can you see this third muscle? This is innermost intercostal muscle. This muscle, if it is present in the thorax, it is innermost intercostal muscle, and when it is in sequence in the abdomen, it is transversus abdominis muscle. This is an incomplete muscle layer and crosses more than one intercostal spaces. It is related internally to the endothoracic fascia and the parietal pleura. See here, parietal pleura is present internal to it, and externally it is related to the intercostal nerve. See here, it is related to the intercostal nerve and vessel, because intercostal nerves and vessels, I have already told you before many times that the intercostal nerves and vessels are present in between these two muscles, which are innermost intercostal muscle and internal intercostal muscle. Now the innermost intercostal muscle is divided into 3 parts. Can you see here? This is the middle part, then there will be an anterior part, and there is a posterior part. The middle part, this is the middle part, which is called as innermost intercostal muscle. When it comes anteriorly, it is called as transversus thoracic muscle. Transversus thoracic muscle, and the posterior part is called as subcostalis muscle. So this muscle has 3 parts. The anterior part called as transversus thoracic, the middle part is called as innermost intercostal, and the posterior part is called as subcostalis muscle. Now again, this is levator costarum muscle. I have shown already to you that they originated from the transverse processes and they will insert over the lower ribs. What is their function? They will elevate the rib. They are triangular muscles and they will elevate the ribs. The serratus posterior muscles we have already discussed. This is superior one, this is inferior one. This is the muscle of inspiration and this is the muscle of expiration, because it will elevate the rib during inspiration, and the lower one, the superior, the serratus posterior inferior muscle, it will lower the ribs, or it will depress the rib during expiration. So the above one is inspiratory muscle, the below one or the lower one is expiratory muscle. Now we will come towards the nerves. The intercostal nerves supply the entire thoracic wall. Why they are named as intercostal nerves? Because they are present in the intercostal spaces. These nerves are anterior rami. See here, this anterior is very, very important. They are anterior rami of first 11 thoracic spinal nerves, because anterior or ventral rami are the motor rami which are supplying the muscles. So So this nerve, see here, this is, they have shown the second thoracic spinal nerve, which will have two rami. This is anterior ramus and this is posterior ramus. Anterior ramus is the motor one, this is ventral, and posterior ramus, which is the dorsal and sensory one. So anterior ramus is the motor one. It will motor as well as sensory also, because it will supply the skin also, because this is the second thoracic spinal nerve, which are mixed nerves, okay, mixed nerves. So sensory as well as motor nerve. So this is anterior ramus. It is formed from the anterior ramus. Again, the anterior ramus will be motor as well as sensory, and the posterior ramus will be motor and sensory. Okay, the anterior ramus of all intercostal nerves will be there, and the anterior ramus of the 12th thoracic nerve lie in the abdomen and runs forward in the abdominal wall as subcostal nerve. This is the another name for the anterior ramus of the 12th thoracic nerve. See here, each intercostal nerve enter the intercostal space. Again, I have already told you, between the parietal pleura and the posterior intercostal membrane. See here in this diagram, this is parietal pleura and this is posterior intercostal membrane. So posteriorly, what will be there? It will enter in between the two, the parietal pleura and the posterior intercostal membrane. Okay, and then it will come in the subcostal groove of the corresponding rib. Then it will come in between two muscles. When it will come forward, the intercostal nerve will come forward. It will be in between the innermost intercostal muscle and the internal intercostal muscle. The first 6 nerves are distributed within their intercostal spaces, because see here, these first 6 spaces, they are true spaces actually, because they are formed where the ribs are attached to the sternum. So here the intercostal nerves are distributed in them. Okay, the 7th to 9th intercostal nerve, they will leave the anterior end of their intercostal spaces by passing deep to the costal cartilage, because these are false rib. Here there are costal cartilages which are attached to one another. So the intercostal nerves will pass deep to the costal cartilages and they will enter the anterior abdominal wall. Okay, because they are related or they are close to the abdomen. Then the 10th and 11th nerve, which are of the floating ribs, they will pass directly into the abdominal wall. Okay, they will pass directly to the abdominal wall. These are the names of the branches which are of the intercostal nerve. Number 1 branch is rami communicants. Okay, number 2 is collateral branch. Here in this diagram they have not shown the collateral branch, but I will tell you, for example, if this is the anterior ramus of the second thoracic spinal nerve, so here what will happen, there will be a small collateral branch which will be deep to it. Okay, small collateral branch. Then this is the lateral cutaneous branch. Okay, this is lateral cutaneous branch and this is also lateral cutaneous branch, and there is anterior cutaneous branch also. For example, in this diagram they have shown the second spinal nerve and the third spinal nerve. The second spinal nerve is giving, this is the anterior cutaneous branch and this is the lateral cutaneous branch, and this is for the third spinal nerve, this is anterior cutaneous branch and this one is the lateral cutaneous branch. Along with the lateral and the anterior cutaneous branches, there are many muscular branches because they will supply the intercostal muscles. There are many pleural sensory branches because they will supply the parietal pleura. There are peritoneal sensory branches also, because the lower intercostal nerves, which are 7th to 11th intercostal nerves, they will run to the abdomen. So they will also supply the parietal peritoneum. So again I will repeat, what are the branches? There are many rami communicants. Number 2, there is a collateral branch from each nerve. Number 3, lateral cutaneous branch. This is lateral cutaneous branch. This is lateral cutaneous branch. Okay, they will reach the skin on the side of the chest. That's why they are lateral. This lateral will again divide into anterior and posterior branches. Then this is anterior cutaneous branch. The anterior cutaneous branch is the terminal portion of the main trunk. So it will reach near the midline and it will divide into medial as well as lateral branches. Then there will be many muscular branches because they have to supply the intercostal muscles. There will be pleural sensory branches because T1 to T6 will supply the pleura and T7 to T11 will supply the peritoneum. So there will be peritoneal sensory branches also. Now, I will explain some of the branches separately. Number one, the first intercostal nerve. See here, this is the first intercostal nerve. What is the main point which we have to learn here? That the first intercostal nerve will give the lateral cutaneous branch. This is the lateral cutaneous branch, and this lateral cutaneous branch will join the brachial plexus. Okay, and the anterior cutaneous branch of the first intercostal nerve does not exist. So what is the important point? That the first intercostal nerve will have no anterior cutaneous branch. It has only lateral cutaneous branch which will enter or which will join the lower trunk of the brachial plexus, because you know this thing that T1 is also giving contribution to the brachial plexus. Number two, the second intercostal nerve. Can you see here in this diagram? This is the second intercostal nerve. Okay, the second intercostal nerve is giving anterior cutaneous branch. This is anterior cutaneous branch, and this is the lateral cutaneous branch of the second intercostal nerve. This lateral cutaneous branch of the second intercostal nerve is called as intercostobrachial nerve. This intercostobrachial nerve will join with the medial cutaneous nerve of the arm. Medial cutaneous nerve of the arm. That's why the second intercostal nerve will supply the skin of the armpit and upper medial side of the arm. That's why in some of the coronary artery diseases, pain is referred along this intercostobrachial nerve and the medial cutaneous nerve of the arm to the medial side of the arm. So pain is referred pain, and if there is any pain of the heart disease, the pain will be felt to the medial side of the arm because of this communication. Again, I will repeat, this is T2, second intercostal nerve. It will give two branches, anterior cutaneous branch, lateral cutaneous branch. Lateral cutaneous branch is called as intercostobrachial nerve. This nerve is connected with the medial cutaneous nerve of the arm in the arm. So what will happen if there is any disease of the coronary artery? The pain will be felt on the medial side of the arm because of this communication. Now, the first six intercostal nerves, we have discussed T1 and T2. Now, along with T1 and T2, the total six intercostal nerves, they will supply the skin and the parietal pleura, because I have told you they are in thorax. Okay, they will supply the skin because they are present on the outer surface as well as they are present on the inner surface. So they will supply the parietal pleura. So the first six intercostal nerves supply the skin and the parietal pleura, covering the outer and the inner surface of each intercostal space respectively. Plus they will supply the intercostal muscles and the levator costarum muscle and the serratus posterior muscles also along because of their muscular branches. See, again we can discuss the branches here. What are the branches? See here, we have anterior cutaneous nerve or anterior cutaneous branch, which will divide into lateral and medial branches. We have lateral cutaneous branch, which will divide into anterior and posterior branches. We have many muscular branches. We have many rami communicants also. So these are the branches of the intercostal nerves. These were in the previous slide, these were the first six intercostal nerves. So supply the parietal pleura. But now the 7th to 11th intercostal nerve, as I have already told you, because they are entering the abdomen, so they will supply the parietal peritoneum instead of parietal pleura. So they will supply the skin and the parietal peritoneum, covering the outer and inner surfaces of the abdominal wall, plus the anterior lateral abdominal wall muscles, not the thoracic wall muscles. Now they will supply the abdominal wall muscles, and these are the names of the abdominal wall muscle. Number one is external oblique, internal oblique, transversus abdominis muscle and rectus abdominis muscle. See here in the diagram, they have shown the rectus abdominis muscle here, and there will be many abdominal muscles in the abdomen, which will be external oblique muscle, then there will be internal oblique muscle, then there will be transversus abdominis muscle, and number 4, rectus abdominis muscle. So the 7th to 11th intercostal nerves will supply skin of the abdomen, parietal peritoneum of the abdomen, and muscles of the abdomen. In previous slide we have discussed that first 6 intercostal nerve were supplying skin and parietal pleura of the thorax of the because they are present on the outer and inner side of intercostal space along with the thoracic muscles. Okay. Now, the skin innervation of chest wall and referred pain. See here, can you see this supraclavicular nerve, the C3 and C4? They are providing the cutaneous innervation of anterior chest wall at the level of sternal angle. At the level of sternal angle. So, supraclavicular nerves C3 and C4, these are supraclavicular nerve. They are supplying at the level of sternal angle. Below this level, the anterior, and these are anterior, see here, and these are lateral cutaneous branches of the intercostal nerves. They supply the oblique band of the skin in the regular sequence. Oblique band, see here, this is the band of T2, this is band of T3, then T4, T5 and T6. Okay, these are the bands, oblique bands, which are supplied on the anterior and the lateral chest wall. See here in this diagram, they have shown the posterior chest wall. The skin on the posterior surface of the chest wall is supplied by the posterior rami of the spinal nerves. So these are posterior rami of the spinal nerves. An intercostal nerve not only supply the skin, as I have already told you, it will supply skin and muscle. Along with the skin, it will also supply the ribs, costal cartilages, intercostal muscles and parietal pleura lining the intercostal space. Furthermore, the 7th to 11th intercostal nerve leave the thoracic wall and enter the anterior abdominal wall to supply the dermatomes on the anterior abdominal wall, muscles of the anterior abdominal wall and parietal peritoneum. This was the revision. This fact that it is supplying the parietal peritoneum, this fact is very important. It is clinically important because it means that disease in the thoracic wall may be revealed as pain in a dermatome that extends across the costal margin into the anterior abdominal wall. For example, if there is a disease that is pulmonary thromboembolism, or there is pneumonia, or there is pleurisy involving the costal parietal pleura, could give rise to abdominal pain and tenderness and rigidity of the abdominal musculature. The abdominal pain in these instances is called as referred pain because disease was in the thorax but pain is in abdomen. This is referred pain because of the dermatomes. Okay. Now, this is another disease which is called as herpes zoster or herpes varicella or varicella zoster or shingles. It is relatively common condition caused by the reactivation of the latent varicella zoster virus in a patient who has previously had chickenpox. This lesion is seen as an inflammation, as you can see in the diagram. This is inflammation and degeneration of the sensory neurons in the cranial or spinal nerve. See here, this is in a pattern. See, this is oblique pattern which is showing the distribution of that spinal nerve which is involved. So, degeneration of the sensory neurons in that spinal nerve. It will be shown as a formation of vesicles. There will be inflammation of the skin. In the thorax, the first symptom is the band of the dermatomal pain in the distribution of the sensory neurons in the thoracic spinal nerve, then followed in a few days by the skin eruption. First there will be pain and then there will be skin eruption. The condition occurs most frequently in patients older than 50 years. This is herpes zoster infection. Now, I will tell you 3 of the procedures. These procedures are very important. You have to learn them by heart because they will be asked in Viva. Number 1 is intercostal nerve block. Okay, again I will repeat. See here, this is the rib above and this is rib below. Okay, can you see the subcostal groove in each of the rib? The subcostal groove is present at the lower border of the rib on the inner side of the rib. In this subcostal groove, 3 structures are present in the VAN or VAN sequence. VAN means intercostal vein. A means intercostal artery and N means intercostal nerve. Okay, if we have to do the intercostal nerve block, so what we have to do, we have to give the anesthetic agent, or we have to infiltrate the anesthetic agent to the nerve to block this nerve. Okay, what happened? The skin and the parietal pleura cover the outer and the inner surface of each intercostal space. You know this thing, that if for example this is intercostal space, the skin will be outside and the parietal pleura will be inside. Okay, what happens actually, the seventh eye, this is also the revision, the 7th to 11th intercostal nerve supply the skin and the parietal peritoneum, covering the outer and the inner surface of the anterior lateral abdominal wall respectively. Therefore an intercostal nerve block will also anesthetize these areas also, that is the skin and the parietal peritoneum covering the outer and the inner surface of the anterior lateral abdominal wall. In addition, the periosteum of the adjacent rib is also anesthetized. Okay, the periosteum of the adjacent rib is anesthetized when we will do the intercostal nerve block. So these are the indications. For example, number 1, repair of laceration of thoracic and the abdominal wall. If we have to do some surgery, okay, because in surgery, you know this thing, the patient can feel severe pain. So to decrease the pain or to make that surgery pain free, we have to do the intercostal nerve block, or for the relief of pain in rib fractures, because in rib fracture the most common or most you can say distressing symptom is the pain. Okay, severe pain in rib fracture. So if we have to give relief of pain and rib fracture, then we will do the intercostal nerve block. Number 3, to allow pain-free respiratory movements, because if there is severe pain in peritonitis or in pleurisy, so what we can do the intercostal nerve block so that the respiratory movement should be pain-free. So these are the indications of the intercostal nerve block. Now I will tell you what is the procedure of the intercostal nerve block. Number 1, to produce the analgesia of the anterior and lateral thoracic and the abdominal walls, the intercostal nerve should be blocked before the lateral cutaneous branch arises at the mid-axillary line. I have told you that the lateral cutaneous branch arises from the intercostal nerve. So see here in this diagram, see if there is clavicle here, and we take the midpoint of the clavicle and draw one imaginary line, that will be called as mid-clavicular line. Then laterally, if we draw one imaginary line in the anterior axillary fold, so that will be called as anterior axillary line. And if we go in the armpit or in the mid of the axilla and draw one line, that will be called as mid-axillary line. Mid-axillary line. So what we will do, see here, we will block the nerve before the lateral cutaneous branch arises in the mid-axillary line. First of all, the ribs may be identified by counting down from the 2nd up to the 12th rib. How we will count them? Because we know this thing, that the 2nd rib is present opposite the sternal angle. This is sternal angle. So this is 2nd rib. Okay, then this is 3rd, 4th, 5th, 6th, and we will block the intercostal nerve of that space in which we have to, at which level we have to do the surgery, or at which level the pain is severe. So we will select, or we will choose that intercostal space in which we have to do the procedure. So the needle is directed toward the rib near the lower border of the rib. Why near the lower border? Because nerve is present at the lower border of the rib. Or we can say we will choose the upper part of the intercostal space, because the subcostal groove is present in the upper part of the intercostal space. This upper part of intercostal space or the lower border of rib is very, very important. They will ask you in exam, in intercostal nerve block, which area you will choose. So we will choose the lower border of the rib or upper border of the intercostal space. Okay, the tip of the needle comes to rest near the subcostal groove, where the local anesthetic agent is infiltrated around the nerve. Okay, remember, all these things are revision. Remember that order of structures lying in the neurovascular bundle from above downward is vein, artery and nerve, and these structures are situated between the posterior intercostal membrane of the internal intercostal muscle and parietal pleura. And as we come forward, okay, this neurovascular bundle will be present between the internal intercostal muscle and innermost intercostal muscle. Okay, I will repeat again. For intercostal nerve block, we will choose the lower part of the rib, okay, or upper part of the intercostal space, because the neurovascular bundle is present in the subcostal groove, which is at the lower border of the rib or the upper border of the intercostal space. Number 2, the intercostal nerve is present below the vein and artery. Number 3, what you have to remember, if we take the intercostal space behind or at the back, so it will be present in between the parietal pleura and posterior intercostal membrane. But if we choose, or if we come forward, or if we come in the middle, in the mid-axillary line, the intercostal nerve will be present in between the two muscles. What are those two muscles? Innermost intercostal muscle and internal intercostal muscle. So these are some of the important points which you have to remember. See here, this is skin. Okay, then this is superficial fascia, then there will be a thin deep fascia. This is serratus anterior muscle, then external intercostal muscle, internal intercostal muscle, and see here, this needle should stop up till here. Okay, we have to choose which part? We have to choose the lower part of the rib and upper part of the intercostal space. Okay, but if we choose this side, what will happen? Tell me. See here, if we choose the upper border of the rib or the lower border of the intercostal space, so what will happen? We can infiltrate the anesthetic agent in the pleura. How? We can pierce the pleura. Okay, see here, we can pierce the pleura. Or sometimes what happen? What we can do, if we do not infiltrate the agent in the nerve, or if we pierce the vessel also. Okay, so these are two most common complications. Okay, number 1, if we pierce the pleura, okay, so what will happen? There will be pneumothorax. Okay, pneumothorax will be there. Number 2, if we pierce the artery, there can be hemorrhage. So these are two complications. Number 1, pneumothorax can occur if the needle point misses the subcostal groove and penetrate too deeply, if we go too deeply through the parietal pleura. Number 2, hemorrhage. It is caused by the puncture of the intercostal blood vessel. So this is a common complication. So aspiration should always be performed before injecting the anesthetic. When we will aspire the needle, and if blood comes in the needle, so this is the point that we can understand that now our needle is puncturing the artery. So we do not have to give the anesthetic agent. We have to take our needle out and go somewhat below, because nerve is present below the artery, so that there should be no hematoma or there should be no hemorrhage in the area. So this was about the nerve. We have discussed the nerves. Okay, there are intercostal nerves which are supplying the intercostal spaces, the skin, the parietal peritoneum, the parietal pleura, and the muscles. Okay, so you know this thing now, that intercostal nerves are the ventral rami of the thoracic nerves. They will supply the skin, they will supply the muscles, they will supply the parietal peritoneum if they are first 6 intercostal nerves, and if they are 7th to 11th intercostal nerve, they will supply the parietal peritoneum. Now we will come toward the vasculature. That is, what are the arteries of the thoracic wall? See here, this is also very important topic. Number 1, the subclavian artery. First of all, see in this diagram, I want to show you some of the important arteries in our body. Can you see, this is the aorta. This is the largest vessel of our body. Aorta, this is the thoracic aorta when it is present in the thorax, and this is the abdominal aorta when it will be present in the abdomen. Okay, this aorta or the arch of aorta is formed by two arteries. There is one right brachiocephalic trunk, and on the left side there are two arteries. The right brachiocephalic trunk is formed by two arteries. See here, this is right common carotid artery, and there is right subclavian artery. On the left side, the two arteries which I have told you are the left common carotid and left subclavian. Again, I will repeat, arch of aorta, there will be arch of aorta which is formed, or what are the arteries or what are the branches? The branches of arch of aorta are the right brachiocephalic trunk on the right side. Right brachiocephalic trunk is giving two branches, the right common carotid and right subclavian, and on left side this is left common carotid and left subclavian. So this subclavian artery is the first artery which is supplying the thorax. Number 2, axillary artery. What is axillary artery? The subclavian artery will be continued as axillary artery in the axilla. So this is the axillary artery which is supplying the thorax. And number 3 is the thoracic aorta. This is thoracic aorta. Again, I will repeat 3 arteries. Number 1 is axillary artery. Number 2 is subclavian artery. And number 3 is aorta. They will give some branches which will supply the thorax. Now we will come toward number 1, the subclavian artery. The subclavian artery will give another branch which is called as costocervical trunk. This costocervical trunk will give one artery which is called as superior intercostal artery. Superior intercostal artery. And number 2 is internal thoracic artery. Can you see this artery? This is internal thoracic artery. So what are the two branches of the subclavian artery? Number 1 is internal thoracic artery and number 2 is superior intercostal artery. Then axillary artery. Axillary artery will also give many branches, but the most common which are supplying the thorax are superior thoracic and lateral thoracic. Number 3, the thoracic aorta, it will give many posterior intercostal arteries and subcostal artery also, which will supply the thorax. So these were the names of the arteries which are supplying the thorax. Now, internal thoracic artery. See here, can you see? This is internal thoracic artery. Internal thoracic artery. This is the branch or first part of subclavian artery. This artery supplies the anterior wall of the body from the clavicle to the umbilicus. It will go till the umbilicus. It is a branch of the first part of the subclavian artery. It will descend vertically down, okay, on the pleura behind the costal cartilages and a finger breadth lateral to the sternum. Here there will be sternum in the middle. So it will be a finger breadth lateral to the sternum and it will end in the sixth intercostal space by dividing into two branches. Can you see these branches? This is superior epigastric artery and this is musculophrenic artery. Again, I will repeat. See here, this is internal thoracic artery. This is the branch of the first part of the subclavian artery. It is present behind the costal cartilages, about 1 finger breadth lateral to the sternum. It will end in the sixth intercostal space by dividing into two terminal branches which are superior epigastric and musculophrenic arteries. Now, some of the branches of the internal thoracic artery, these branches are very, very important. Remember one thing. Every intercostal space is supplied by two small anterior intercostal and one large posterior intercostal arteries. And you should know this thing, that from where these anterior intercostal and posterior intercostal arteries are coming. Okay, I will revise all these arteries again. Okay, but first of all, remember the branches of the internal thoracic artery. See here, number 1. Two anterior intercostal arteries which are supplying the upper 6 intercostal spaces. That is space number 1, 2, 3, 4, 5 and 6. These anterior intercostal arteries, which are 2 in every space, they are branches of internal thoracic. Number 2, perforating arteries. Number 3, pericardiophrentic arteries, which will supply the pericardium. Number 4, mediastinal arteries, which is obvious from the name that it will supply the mediastinum. And I have told you two terminal branches. One is superior epigastric and one is musculophrenic artery. So these are the branches of the internal thoracic. They are very important. Number 1, anterior intercostal. Number 2, perforating. Anterior intercostal of how many spaces? Only 6 spaces. And how many anterior intercostal in every space? 2 anterior intercostal in every space. Number 2, perforating. Number 3, pericardiophrentic. Number 4, mediastinal. Number 5, superior epigastric artery. Number 6, musculophrenic arteries. Okay, so these are the branches of internal thoracic. Now, as I have already told you that you should remember intercostal arteries, that from where they are coming. This is the important point which I have told you. Each intercostal space contains a large single posterior intercostal artery and two small anterior intercostal artery. I will explain anterior intercostal arteries first because we have discussed the branches of internal thoracic. So the anterior intercostal arteries of first 6 spaces are the branches of internal thoracic artery. And from where the internal thoracic artery is coming? It arises from the first part of the subclavian artery. The anterior intercostal arteries of the lower spaces, that is 7th space, 8th and 9th space, these are the branches of musculophrenic artery. And what is musculophrenic? It is the one of the terminal branch of internal thoracic artery. So subclavian artery, its first part will give internal thoracic. Internal thoracic will give upper 6 anterior intercostal arteries, and the lower anterior intercostal arteries are the branch of musculophrenic. And from where the musculophrenic is coming? It is one of the terminal branch of internal thoracic. What is the other branch of terminal branch of internal thoracic? That is superior epigastric artery. Okay, now the posterior intercostal arteries. The posterior intercostal arteries of first 2 spaces, they are branches of superior intercostal artery, which is the branch of costocervical trunk, which is a branch of subclavian. Again, I will repeat, subclavian will give costocervical trunk. Costocervical will give a branch which is superior intercostal. Superior intercostal artery will give posterior intercostal arteries of first 2 spaces only. Then the posterior intercostal arteries of lower 9 spaces are the branches of descending thoracic aorta. Remember one thing, that the aorta has 3 parts, okay, in the thorax. Number 1 is ascending aorta, then the arch of aorta, then the descending thoracic aorta. So this descending thoracic aorta is giving posterior intercostal arteries of lower 9 spaces. So this slide is very important for MCQs. Okay, these things will come in your MCQ, that the posterior intercostal arteries of first 2 spaces are the branches of superior intercostal, and superior intercostal is a branch of costocervical trunk, which is a branch of subclavian artery. Posterior intercostal arteries of lower 9 spaces, they are branches of directly from the descending thoracic aorta. Anterior intercostal arteries of first 6 spaces, they are the branches of internal thoracic artery, which is the branch of first part of the subclavian artery. Then the anterior intercostal arteries of lower spaces are the branches of musculophrenic artery, and one which is one of the terminal branch of the internal thoracic artery. I hope you have learnt it by heart. Now, each intercostal artery is giving off branches to the muscles, to the skin and the parietal pleura. The anterior and posterior intercostal arteries, they typically anastomose with one another at approximately the costochondral junction. What is costochondral junction? Costo means rib, chondro means cartilage. So when the rib is ending in the cartilage, at that point the anterior and posterior intercostal arteries, they are anastomosing with one another. Okay, now we will come towards some of the veins which are draining the venous drainage, or which are draining the venous blood in the thorax. Number 1 are posterior intercostal veins, and number 2 is anterior intercostal. Okay, anterior intercostal vein drain anteriorly into the internal thoracic and musculophrenic vein. Just like the anterior intercostal arteries are the branches of internal thoracic, which are first 6, and lower are the branches from the musculophrenic arteries. And the posterior intercostal veins, which were the branches of the descending thoracic aorta in the lower 9 spaces, and above 9 were the branches, as we have discussed, were the branches of superior intercostal arteries. So superior intercostal vein and costocervical trunk was there, and subclavian arteries. So similarly, now what will happen? they will drain into two main veins. See here on the right side we have a big vein which is called as azygous vein. On the left side we have hemiazygous vein. Hemiazygous. So the corresponding, if the posterior intercostal veins are present on the right side, they will drain in the azygous vein, which will drain in the superior vena cava, and the posterior intercostal veins of the left side, they will drain in the hemiazygous vein because it is present on the left side. Now, if there is any internal thoracic artery disease, internal thoracic artery in the coronary artery disease treatment, what will happen? In the patient with the occlusive coronary artery diseases, which is caused by atherosclerosis, a disease arterial segment can be bypassed by inserting a graft. Okay. Sometimes what happen? Internal thoracic artery can be used, but most of the time great saphenous vein is used, okay, as a graft. Okay, but sometimes the myocardium can be revascularized by surgically mobilizing one of the internal thoracic artery and joining its cut end to the coronary artery. So internal thoracic artery can be used as a graft in the coronary artery disease treatment. I have already told you that there is arterial anastomosis between the anterior intercostal and posterior intercostal arteries. So the anterior intercostal arteries, which are the branches of subclavian artery, may be through the internal thoracic, which are first 6, and musculophrenic, which are lower 5, and the lower 9 posterior intercostal arteries, which are the branches of descending thoracic aorta. They typically anastomose with one another at approximately the costochondral junction. These important connections create the collateral circulatory routes that potentially allow the blood flow to bypass the obstruction in the thoracic aorta or the proximal part of the subclavian artery. These anastomoses are notably prominent in circumventing the constriction present in the postductal coarctation of aorta. That is, I will tell you, if there is narrowing of aorta, for example, if the blood is not passing through the aorta and not passing to the other branches of the descending thoracic aorta and abdominal aorta, so what will happen? Those areas which are supplied by the aorta will not get blood. So there will be anastomosis between the internal thoracic artery, okay, which is above, and other branches also, okay, and the musculophrenic arteries and other branches of the thoracic aorta, they will anastomose. And what are those branches? Anterior intercostal arteries and posterior intercostal arteries. So they will bypass that coarctation of aorta and the blood will be supplied to those areas which are not getting blood due to coarctation of aorta. Now, this is one slide for the thoracic wall lymphatic drainage. See here, the lymphatic drainage of the skin of the anterior chest wall, it will drain into the anterior axillary lymph nodes, and the posterior chest wall will go into the posterior axillary lymph nodes. The lymph drainage of the intercostal spaces, they will forward into the internal thoracic nodes, which are situated along the internal thoracic artery, and posteriorly to the posterior intercostal nodes and the para-aortic nodes in the posterior mediastinum. Now, the remaining two procedures which are very important, and you have to listen them and you have to learn them by heart. Number one is needle thoracostomy. Thoracostomy is a word which is used for a procedure in which we will insert a needle. If this is a needle thoracostomy, so we will insert a needle, but there can be a tube thoracostomy also in which we will insert a tube. So first of all, I will discuss the needle thoracostomy. Needle thoracostomy is the creation and maintenance of an opening into the thoracic cavity by using a needle. For example, when we will do the needle thoracostomy, number one indication is tension pneumothorax. For example, if air is present in the pleural cavity and it is under pressure, or if there is increased amount of air in the pleural cavity, and if we have to drain that air out, okay, which is the treatment of pneumothorax. So what we will do, we will insert a needle in the pleural space and we will make a wave so that the air can come out. Number two, to drain the fluid if there is blood collection or pus collection, okay, in the pleural cavity, and we have to drain that fluid out to allow the lung to re-expand. Number three, if we have to withdraw a sample of the pleural fluid for microbiological examination. These are three indications in which we will insert a needle in the pleural cavity or pleural space. Now, there can be two approaches for the needle thoracostomy. Can you see in this diagram? This is anterior approach. Anterior approach means if we insert a needle anteriorly, or there can be a lateral approach. In the anterior approach, the patient will lie in the supine position. What is supine position? When we lie on a bed, okay, by facing upward. So it will be supine position. So what we will do, we will identify the sternal angle. See here in this diagram, this is sternal angle. So we will identify the second costal cartilage, the second rib. This is second rib and this is second intercostal space. So we will choose the second intercostal space in the mid-clavicular line. This is very, very important. In exam, it will be asked to you that what is the point at which needle thoracostomy is done. So where needle thoracostomy is done, it is the second intercostal space in the mid-clavicular line. That is the midpoint of the clavicle, second intercostal space. How we will identify the second intercostal space? We will identify the sternal angle. Second costal cartilage is attached to the sternal angle. This is second rib. Then below the second rib is second intercostal space. So in the mid-clavicular line, we can insert a needle. But in the lateral approach, what we will do? See here, we will count from the sternal angle. This is second rib. Then this is third rib. Then this is fourth rib. And this is fifth. This is fifth intercostal space. This is second intercostal, third and fourth. Then there will be fifth intercostal space. So we can take the third intercostal space or the fourth intercostal space or the fifth intercostal space, but in the anterior mid-axillary line. See here, this is the mid-axillary line. This is lateral approach. Lateral approach in the thoracostomy, in the needle thoracostomy. Okay, we will choose the anterior axillary line, anterior mid-axillary or anterior axillary line. Okay, in the lateral approach, the patient is lying on the lateral side. Okay, the second intercostal space is identified as above, but anterior axillary line is used and the skin is prepared in the usual way. A local anesthetic is introduced along the course of the needle above the upper border of the third rib. See here, this diagram is very, very important, which I have. This is the diagram for the needle thoracostomy. So what area we will choose? We will choose the upper border of the rib. Why we will choose the upper border of the rib? Because if we choose the lower border of the rib or the upper part of the intercostal space, we can touch or we can insert the needle in the vein or the artery or the nerve, which we do not have to do. Actually, we have to go in the pleural space. So what we will do? We will avoid this neurovascular bundle by inserting our needle in the upper border of the rib. Okay, we will not insert the needle in the lower border of the rib because neurovascular bundle is present here. So these are the structures which we will pierce. Number one, skin, then superficial fascia. Okay, then there will be serratus anterior muscle, external intercostal muscle, internal intercostal muscle, innermost intercostal muscle, then there will be endothoracic fascia, then there will be parietal pleura, and then the pleural space will come. Okay, then this point is very, very important. The needle should be kept close to the upper border of the third rib to avoid injuring the intercostal vessel and nerve in the subcostal groove. Okay, to avoid injuring the intercostal vessels and nerve in the subcostal groove. Okay, so we will insert in the upper border of the third rib. Okay, because in the second intercostal space, actually in the needle thoracostomy, we will choose the second intercostal space. Okay, but in the tube thoracostomy, see here, this lateral approach, the fifth intercostal or the fourth or fifth or third intercostal, usually we take in the tube thoracostomy. But for the needle thoracostomy, we can choose the anterior approach or lateral approach, but we will take the second intercostal space. Okay, second intercostal space. Now in the tube thoracostomy, the preferred insertion site for a tube thoracostomy is the fourth or fifth intercostal space at the anterior axillary line. Okay, I will repeat again. See here from this diagram you can remember, for needle thoracostomy we will choose the second intercostal space by two approaches. Anterior approach is mid-clavicular line. Lateral approach will be anterior axillary line. Anterior axillary line. But for the tube thoracostomy, we will take the mid-axillary line, not the anterior axillary, mid-axillary line, and fourth and fifth intercostal space, not the second intercostal space. Okay, so in the tube thoracostomy, the tube is introduced through a small incision. We can give a small incision. You can see here. This is tube thoracostomy. The neurovascular bundle changes its relationship to the rib as it passes forward in the intercostal space. I have told you in the most posterior part, it was in the middle of the intercostal space. Okay. For example, see here, if we take posterior part, so the neurovascular bundle is in the middle. But as we come forward, the neurovascular bundle is related to the costal groove that is present to the lower border of the rib. Okay. So, and it will maintain its position forward also. So what we will do, we will insert the tube and we will avoid the lower part of the rib. We will take the lower part of the intercostal space, not the upper part of the intercostal space, to avoid the injury to the neurovascular bundle. This is very, very important. Okay. Same thing is written here. The introduction of the thoracostomy tube or needle through the lower intercostal spaces is possible provided that the presence of the dome of diaphragm. You have to remember this thing, that the dome of diaphragm as they curve upward into the rib cage as far as fifth rib. So we have to avoid damage the diaphragm and entering the peritoneal cavity and injuring the liver, spleen or stomach. So we have to avoid all these things, because that's why for the thoracostomy, whether it is of tube thoracostomy, we will insert up till the fifth intercostal space. Okay, because if we will go below it, there will be diaphragm and then there will be liver, there can be stomach, spleen. So we have to avoid the below spaces. Okay, so as to avoid the injury to the diaphragm or to the intra-abdominal organs. So this was about tube thoracostomy and needle thoracostomy. Now the last thing which we have to learn is thoracotomy. Thoracotomy is a procedure in which we give one incision, okay, so that we can have access to the pleural space, or we can gain access to the heart or to the aorta. This may be a life-saving procedure in patients with the penetrating chest wounds with uncontrolled intrathoracic hemorrhage. After preparing the skin in the usual way, the physician makes an incision. See, remember this area over the fourth or fifth intercostal space, extending from lateral margin of the sternum to the anterior axillary line. We will give a big incision here, okay, in which we will give incision from the lateral margin of the sternum till the anterior axillary line in the fourth or fifth intercostal space. Whether to make a right or left incision, it depends on the site of injury. The chest should be entered from the left side for the access to the heart or aorta. Okay, the following tissues will be incised. For example, number 1, we will cut the skin. Then subcutaneous tissue will be there. There will be serratus anterior muscle and the pectoral muscles will be there. Pectoralis major muscle and the pectoralis minor muscle, which is attached to the third, fourth and fifth rib. Okay, that will be pectoralis minor, which is shown in this diagram also. So if we are cutting in the fourth intercostal space or the fifth intercostal space, the pectoralis minor muscle can also come in the way. Then we will cut the external intercostal muscle. Okay, we will retract all these muscles and anterior intercostal membrane, which is the anterior part of the external intercostal muscle. Then the internal intercostal muscle will come. Then innermost intercostal muscle will be incised. Then there will be endothoracic fascia and parietal pleura. We have to avoid the internal thoracic artery, which runs vertically downward behind the costal cartilages and about 1 a finger breadth lateral to the margin of the sternum, and we have to avoid the intercostal vessels and nerve which extend forward in the subcostal groove in the upper part of the intercostal space. So we will give one incision. See here in the fourth or fifth intercostal space, it will be from the lateral margin of the sternum until the anterior axillary line. So this is very, very important. See here. Okay, this is called as thoracotomy. We will do this incision, we will cut this skin and everything, and then we will gain access to the heart or to the aorta or to the pleural cavity or to the lungs. In the lung cancer also, in any other problem, we will do this procedure.